However, if we look further down for more long-term survival up to 5 years, numbers decrease very rapidly. And here we think there is an option to improve the statistics and maybe the option of using adoptive cell therapy. So we have used and are sort of focusing on adoptive cell therapy using tumor infiltrating lymphocytes, so T cells from the patient's tumor. There are many clinical trials over the whole world that are using this setup, using TILs. However, there are still some problems that we have to improve before we can treat many patients with a high efficiency. One of the problems is that there's a lack of a strong re-stimulation of the TILs after they have been fused into the patient. They need to have a re-stimulation after infusion so you can have a long and efficient persistent in the patient. The second problem is that they're exposed to a very suppressive tumor environment after infusion. However, our lab has focused on the first point. So we are trying to give the TILs a very nice re-stimulation after infusion to the patients using an autologous DC vaccine. So we have our own GMP facility at CCK in Solna. It all started with a pilot study where it was studied if it was safe and it possible to generate high numbers of TILs and combine that with the autologous DC vaccine. When that study was finished, we started a second trial called MAT02, and that is what I'm going to talk about today. And in this trial, we are treating patients with advanced melanoma using high doses of TILs in combination with an autologous DC vaccine. I think in total we have treated around 25 to 30 patients, and we are the only site in Sweden that are allowed to give TIL therapy. So I just want to show you a little bit on how we generate our TILs or T cells to give them back and treat the patient. So it all starts with the tumor lesion that is operated out, or we can start with several of core biopsies if it's not possible to do an operation. Then we harvest the tumor and then we split it into microfragments, which we stimulate with IL-2, really high doses of IL-2. But this first part, the actually first step, can be really tricky, and we have worked a lot to optimize it. First of all, we need to have enough material. As I said, we can also start from core biopsies, but then it really needs to be viable cells in those core biopsies. In this case, you can see that we got a huge amount of tumor. This part here is only a fifth of the tumor that we got, and this is only the remainings that we had after we had set up everything in our GMP lab. What is also very important is that you keep your specimen very sterile, and that can be very difficult when you work with a cell type or a tumor type like melanoma, since it comes from the skin with a lot of bacteria, and especially if you get the tumor piece like this that you already have hair follicles, etc. in it. But then we make it into microfragments and put it up in plates to expand the T cells within the tumor piece. And that takes approximately 2 to 4 weeks until we have enough cells to start the big expansion step, the rapid expansion. We have decided to make our rapid expansion in 2 different steps. We start by having them in a flask setting, and then we go to a closed wave reactor setting that Katrin will talk much more about in the next session. But what is very important here is that we stimulate our T cells with autologous irradiated feeder cells. And that is the intention to sort of give, while the cells are dying off in our cell culture, they will release a lot of cytokines and signals that will lead to high proliferation of our T cells. In addition, we also stimulate with anti-CD3 to to get a very fast expansion. This step has been very time consuming and it's taking a lot of optimization to get it to work. Both you need to know what numbers of TILs you have to start with to start this big expansion so that you can have so many cells as 60 billions in the end. We have also seen that you need to have a very good condition of your feeder cells before you radiate them, because otherwise they don't give the boost of the expansion that you want to. You also need to have sort of enough cells to transfer to the wave bag, and that is a very important key step that Katrin will talk much more about. We both expand the rapid expansion in the wave, but also in a G-Rex flask looking like this, which is an option to the wave bag that is handled at Vecura. We normally have these G-Rex bags or flasks as a backup system if anything would fail. But this step took us a lot of optimization before we could continue with high numbers of T cells. After, when we have succeeded with the expansion, we have to test that it's sterile, the product of course, because it's giving back to the patient. And then we infuse it in around 30 to 60 billion T cells is what we are aiming for. So our clinical trial is divided into two cohorts, cohort A and cohort B. Cohort A goes through surgery, so we get material to start the TIL production. And they go through lymphodepletion, making room and space for the new cells that are arriving. And we give back the T cells in combination with IL-2. What is unique with our clinical trial is cohort B, where we go through the same procedure of surgery, lymphodepletion, and pill infusion in combination with IL-2. But after that, we have a autologous DC vaccine program. We start to infuse once a week, 3 weeks after the TIL infusion, and then we give them 5 repetitive doses of this DC vaccine. I just want to show this ugly picture because I want to emphasize how much coordination it is to run this clinical trial. We both have to coordinate everyone at the oncology clinic in Solna who is emitting and seeing all the patients. Our GMP lab that are producing everything until the second step of our rapid expansion. And then Vecura, who does the bioreactor step. And then also us for making the dendritic cell vaccine, and also the stem cell transplantation unit in Huddinge, both for harvesting these cells for making the DC vaccine and CAST for emitting the patients for lymphodepletion, infusion of the cells, and also the bit toxic IL-2 treatment. So we use a 2-step immunotherapy, both TILs and then the DC vaccine. So we get a big leukapheresis product containing monocytes that we are maturing out into the immature dendritic cells, and these are loaded with the tumor lysate. So the same tumor as the TILs are generated from, we also take to make the tumor lysates that we load on dendritic cells to make the DC vaccine. The idea here is that this tumor lysate should contain antigens that T cells have recognized in the tumor before and could therefore re-stimulate and boost the TIL after infusion. Again, we have these 2 steps, and I will only talk about the second cohort today because cohort A was filled with a lot of problems and optimizations, and also we had the problem of having 2 different types of melanoma. We had patients with uveal melanoma and cutaneous melanoma. It's very difficult to compare how to treat these 2. But the results from the second cohort are very encouraging, and I want to share them with you. So for the first patient in the second cohort, it was a female. She was 69 years old when she came to us. She has progressed on, I think, both BRAF inhibitors and also checkpoint inhibitors. And as you can see from this PET scan that she has a lot of black metastases everywhere, or several. And when she is giving a radioactive labeled glucose, the tumor lights up because it uses the glucose. You can see them in yellow here. And then she received 35 billion of TILs in combination with 5 dendritic cell vaccines doses, and you can see that her tumors are disappearing. However, she has a little bit remaining here, which is very stupid and unlucky that they cut off from this slide, but she has a little bit remaining. So she's a very strong partial responder, but she has no sort of remaining disease except this, but it's not progressing in any way. So she has been stable for 4.5 years now after treatment. The second patient was a male in his 50s. You can see that he has a lot of different metastases. And then after treatment with 30 billion TILs and these vaccines, he has any more metastases left from his disease. And 4 years after treatment, he is now a complete responder and disease-free. Our third patient is a bit of a special case. As you can see, he has a lot of metastases in the upper thorax and in the abdomen. And he was treated with TILs and these vaccinations. And as you can see, some of these mutations or these big tumor burdens, they actually shrunk a lot and are actually gone almost. However, he got the complete different disease picture, unfortunately, with small metastases, and he passed away 4 months after the treatment. The fourth patient in this cohort was a 60-year-old farmer. He had to remove his leg before he came to us due to this disease. Then his melanoma unfortunately came back. He had also progressed on checkpoint inhibitors, as all of this patient has gone through as a standard of care treatment. Then he got 48 billion of TILs in combination with a DC vaccine. And you can see now he has no more any tumor burden, and now he has been disease-free for 2 years after his treatment. So I want to point out how much tumor burden these patients actually have and how sick they are. Many of these patients come to us and we generate T cells, and it takes approximately 6 weeks to produce. And meanwhile, several of them has passed away before we have been able to produce the T cells in these 6 weeks. So that these patients have survived 4.5, and 2 years after the treatment, I think are very important and results to be happy about. And of course, we want to see a little bit what are these T cells actually recognizing. Why do they clear the tumor this efficiently? So we have looked at the T cell repertoire in these samples. What we have done is that we have collected blood sample before the T cell infusion and of course the T cell product, and then afterwards at random time points when they have come back to sort of see the doctor for checkup. And then we have sent these samples for TCR sequencing and amplification to a biotech company and looked at the T cell clones. So if we go back to our first patient, the female, you can see in this gray bar is before her infusion of TILs. And this gray means that none of the clones are bigger than 0.1%, or they do not exist in TIL pool. This is her TIL product, and you can see that every color represents one different clone. So she has many big clones, except for this gray scattered area, which is composed of several clones that are 0.1 to 3% in size. They are too small to show like this. But what's important to see is that this is what we infuse. And yes, some of the clones expand and some of the clones are decreased in size, but however, they are sort of staying for a very long time. We only measure them till 118 weeks, but she still have sort of the same clones, even in different sizes, and some new has also appeared. So 2 years after infusion, we can still detect the T cell clones that we infused her with. Then I will jump a little bit to this mixed response patient. As you can see, he has very few clones, but they're quite big instead. And after infusion, one clone takes over. And also this clone we could detect in this sample. We got an ethical permit to take skin biopsies, and we can also detect this clone in the skin. So what we've done is that we infused the cells, we wait 3 weeks, and we gave the first DC vaccination. 4 days after the DC vaccination, we got the skin biopsy either from the injection site or from the control site. I could not grow any T cells from the control site. However, from the DC vaccination point, I can grow these T cells, and you can see that the big portion is the same clone as we found before. So what I think happened here is that you have these big tumor lesions. Our T cells, clone number 1 here, recognizes the big tumor burdens we have here and proliferate a lot. And it proliferates on the expense of these clones here. Now tumor cells that express antigens that are recognized by these clean T cell clones can grow out, and that is what we see here with a complete new disease picture. So to conclude my part from this in this talk, we want to say that it's actually possible to treat patients with advanced melanoma using adoptive cell therapy in combination with a DC vaccine. And we can see really long-lasting clinical responses, even though the patients had already progressed on checkpoint inhibitors. And we saw actually responses up to 4.5 years after infusion, which we are very happy with, since we know that many of these patients die within 6 weeks before we can treat them. What we also saw that is that we can detect our T cell clones in the blood up to 2 years after infusion, and that we can also see them in the skin at the vaccination site, indicating an effect of our vaccine. We are now working on to find out what are these T cell clones and what do they actually recognize. And we do this in collaboration with the company Anocca. We also got the ethical permit to include 10 more patients into this arm, giving both T cells and a dendritic cell vaccine, which we are very happy with. And we are trying to include them. However, it's very difficult to work with melanoma since there are so many clinical trials. So it's like a fight of the patients who would get them, can include them into their therapy. So now we are also expanding and trying to see what other types of tumors could we go for to use TIL therapy and also dendritic cell vaccine. And then I will stop and give the rest to Katrin. Thank you for listening. Are there any questions so far?
I was just about to say, let's take the questions at the end, because I think we'll have a decent amount of time at the end. So okay. You can see them listed here. You can think of your responses.
Okay, yeah.
You are welcome, Katrin.
Thank you, Heather. I'm working on it. So, okay, I'm just gonna have the pointer as well. Okay. So my name is Katrin Markland, and I work as production manager at Vecura, which is the GMP facility at the Karolinska Cell Therapy Center. And I'm going to talk a little bit about the process optimization that Stina talked about. Yeah. So this is also a sort of messy slide, but this is what we do when we start a manufacturing process. We prepare a process flow chart. And this is the flow chart that we did in the beginning using a small scale reactor. So in this picture, you can see some different colors. So you have the pink ones, which are patient-related steps that we use. We have blue boxes, that is process production steps. The orange ones are quality control steps. And then we have green over here that are the release procedure of the TILS product. So I'm not going into all these different boxes, but up here you see the different the preparations that are performed with the patient. And then here you have the first part, which is the TILS pool. And you can see you take a tumor, you seed tumor pieces in 24-well plates, you culture for 2 to 3 weeks. And after this time, you harvest the TILS and you start the rapid expansion. And the rapid expansion is, like Stina said, divided in 2 parts. You have the first part that is performed at CCK in Solna. And that's a 6-day process where you culture the cells, the TILS, with feeders. On day 6, we transport the cells south from Solna to Huddinge and to Vecura, where we start the rapid expansion protocol part 2. And in this part, we do the closed culture in the cell bag for another week. We harvest cells. After 14 days, we formulate, and then we release the cells to the patient. And this is a fresh product, so we have a 2-hour shelf life from completed formulation until the cells needs to be inside the patient. So we need to be really fast when we release and transport the cells to the clinic. We manufactured the first batch of TILS in 2013. So at that time, we had a 0.5 liter working volume in the bioreactor. And as you can see for this batch, we had 86% viability of the cells that we got from CCK and that we put into the bioreactor. But initially, the viability decreases. So on day 2, we only had 50% viable cells remaining. But during the culture, it increases nicely. And in the end, we had 99% viable cells. And you can also see that the cells expanded nicely. So in the end, we had 14 billion cells that were transfused to the first patient. And we were very happy with these results, and we had a good feeling for the coming batches. But as you can see here, it was only the first batch, the blue line, that was successful. The 3 following batches are down here in cell numbers. So basically the cells didn't expand. You can see the dotted lines over here are the viability. So both the 3rd batch and the 7th batch, we had an okay viability, but still the cells didn't expand. And then we had the catastrophic one, which was batch 6, where the cells basically just died off. So this is an overview of these batches. And when we compare them, we see that batch 6, we had a lot more cells that were inoculated into the bioreactor. But despite this, we only got 16 million cells at the end of the culture. And this probably depends on the fact that we had basically 13% conditioned medium that was transferred with the cells to the cell bag from the static T flasks. So we had some challenges with this small scale process, and we could identify some factors that made these cultures a bit more challenging. Number 1 was that we didn't have a defined criteria on how many cells that we needed to transfer to the cell bag to start a culture. And we didn't have a criteria for how much conditioned medium to transfer from the T flasks to the bioreactor. Number 2, we had autologous serum or plasma that was supplemented in the media, but in some cases we didn't have enough since it was autologous, so we couldn't get 2% like we wanted to. Number 3, when we had a poor cell growth, we didn't want to add media because we don't want to dilute the cells below a certain cell concentration. And that means that we can't reach the working volume in the cell bag and we can't start the perfusion. And the media is evaporating a little bit, so we get a high osmolality, which is also not good. We didn't have a defined profile either for perfusion or rocking or the tilting angle of the bioreactor. So these parameters were adjusted basically due to the fact how the cells looked and the amount of metabolites in the medium. So we had a number of challenges with a small scale process. So what did we do then? Well, we got a little help from our friends. So we had contact with another research group at the Herlev Hospital in Copenhagen that Rolf Kissling knows and has contact with. And this group is led by Inge-Marie Svane, as you see up here. So we were able to get their SOP for how to culture these TILs for melanoma patients. And myself and Tanya from Rolf's group, we were able to go to Copenhagen on a study visit during one of their TIL batches to get some more pointers. So what did we do then? How did we modify the process? Well, if we look at the first week where we have the static T flasks, if we used a frozen TILs pool, then the TILs pool were thawed and rested for 2 days before starting the actual rep. We had a strict limit for how much cells to inoculate in the T flasks, and we also used larger T flasks. Then we defined a strict ratio of the feeders versus the TILs. We replaced the autologous serum plasma with commercial one, and we increased the IL-2 concentration 10 times. And finally, we left the cells in the T flask for 1 extra day before we transferred to the cell bag. And looking at week 2 in the rep, we switched the cell culture bag from a 1 liter bag to a 10 liter bag, where you can have 5 liter working volume. We defined how many cells to inoculate at the minimum. So we need minimum 1 billion cells to be able to start. And we also defined that all conditioned medium from the T flasks should be transferred to the bioreactor. Also in this step, we increased the concentration IL-2 10 times. And we decided predetermined perfusion profiles with increased perfusion rates, so that we don't use the metabolite data anymore to decide how much to perfuse, but it's a fixed profile. And starting with batch 11, we replaced the culture medium to another medium with a little bit more glucose in it. And with the new medium, we could skip adding plasma or serum to the culture medium, because the new medium already had human serum albumin in it. So then we didn't need to supplement with more plasma or serum. So this is what it looks like now. And you see it's still a lot of different steps. And it's basically the same steps, but just a bit more defined. So I'm still not going to go into these all these steps. So let's look at some results then. Here you have the growth curves on batch 8 to 17. And as you can see, you have these first 3 batches, 8, 9, and 10. They were the ones using the old culture medium. And then from batch 11, you have the new culture medium. And in the first large-scale batches, we got approximately 30 billion cells using the old medium. And then we have gotten a bit more cells with the new medium, from 35 to 55 billion cells. But you can also see that we still get cultures that do not perform as expected. So this is from our last culture, and we only got like 15 billion cells. So they are still a bit, they not always do like we want them to do, these little cells. Viability, if we move on to that, we see that early after transfer to the bioreactor, the viability varies a bit. In this culture, we only had 60% viable cells, but it picks up. So at the end, we still have, or we have a high viability. And the limit that we have is 70% viability at harvest. So we are well above that at the end of the culture. During the culture, we measure the concentration of glucose and lactate. And for the glucose, we want to stay above 2 millimolars. And as you can see for these 3 batches, 8, 9, and 10, which was the old culture medium, we were kind of close to this limit. And throughout the culture, we increase the perfusion rate, but we still remain quite close to these 2 millimolars. And in contrast, you have the new culture medium up here, where you see that we have more glucose in the medium, and the glucose level increases when we increase the perfusion rate. So we have a bit more sugar for the cells to grow on with the new medium. And looking at the lactate, you see here that we have an increase in the beginning in lactate, but that's as expected. The cells are growing, they produce lactate, and we don't have a perfusion directly from the start in the bioreactor. So it's not strange that the lactate increases. But then when you see that we start the perfusion and then the lactate concentration starts to decrease. Here you see an overview of the different batches that we have produced. And the first 4 batches, 1, 3, 6, and 7, are the small scale batches using the non-optimized process. And then from batch 8 through 17, it's the optimized process that we have used. And as you can see, even in the optimized process, we still occasionally, like in batch 8 and batch 12, start with less cells than we ideally would like to have, which was 1 billion cells. But anyway, with the optimized process, we still manage to have the cells expand and we get a high cell number. But as you can see, we still have some variation in the number of cells, in the patient doses, in the number of generations, and in the expansion factors. But we also have to keep in mind that this is an autologous product, so it's difficult to know if these variations are process-related or if they are in fact patient-related. So to conclude my talk, the optimized process has resulted in a more well-defined and stable process with less risk of process failure. And this in turn has led to more cells in the patient dose. So myself and Stina, we would like to thank you for listening. And as you can see, we have a long list of people that's involved in this project and that we want to thank. But primarily, we would like to say thank you to the most important persons involved, and that's the patients that are willing to participate in this trial. So thank you.
Great, thanks, Katrin. Bill, you can start sharing your screen. Bill will be the last speaker in this one, and then we can get on to some questions. Bill from Cytiva.
Hi, hello there. Yeah, just pulling up presentation. All right, so guys, you should be able to see my screen now. Yep. So first of all, thank you very much for the invite to speak here today. It's a real pleasure to be presented to this community that off and on I personally have been involved with for 7+ years or so, but obviously through GE Healthcare, who recently acquired this part recently divested, sorry, this part of their business to the Danaher Corporation, and we are now called Cytiva. So everything that was GE Healthcare Life Sciences is now Cytiva, just to put a bit of context around the name. So I'm going to present today just on some of the work that we've been doing around automating the cell and gene therapy manufacturing workflow. And it touches on the work that we were doing together within this collaboration, but I'll also give a case study from a collaboration that we've been doing in the UK. So this is a generic-ish workflow for cell therapy manufacturing. It is focused on autologous and autologous CAR-T for that matter, but all of these processes, certainly on the autologous setting, start with the acquisition of some starting material, which usually has to be transported somewhere. More often than not, that's cryopreserved, or it's cryopreserved until it can be fitted into a manufacturing slot. Then here, we pictured in this green box is the equipment, certainly that our organization and consumables that our organization contributes to this workflow. And then there's the final step of getting that therapy back to the patient. There's 2 logistic steps involved with this, usually again at cryogenic temperatures, and this is where I'll just point to a little case study that we've been working on. The automation piece for us encompasses everything inside this light blue sort of dotted line that you can barely see, which we are considering from a manufacturing perspective to be included in the workflow. So it's acquisition of the starting material into the manufacturing process and then back out again. And using a software platform called Chronicle, we are looking to introduce automation as far as is possible, and also a significant element of control into this process from start to finish. Next slide. So acquiring that starting material, there's a bit of focus on that, but not necessarily. It's complicated. We've seen from the previous 2 presentations that the quality of the starting material is critical if you're going to get out of it an effective therapy. And numerous things can impact on that, from the patient themselves through to how it's processing, how it's processed, and by whom. Then it's got to get to the manufacturing center. The appropriate temperature control timing, as we heard, is absolutely critical in this. And then those processing capabilities, how long it takes, choice of materials. Are we going for manual processes, or can we close that? And that's certainly something as an organization we're looking very closely at, and time again being critical. So if we want to just look at shipping and moving these from about, now within the Stockholm greater area, you're moving across a city, which is one thing. But what if that involves even greater steps, greater distances across national borders, etc.? It's a massively complicated process. So this sort of combined line, if you like, from here just depicts a starting material from a clinical site being transited across and finally ending up in a manufacturing workflow at the end here. And this is just the one way from the starting material into. And there's numerous people involved with this. So you could be getting a shipping container from a managed service. You might own that shipping container yourself. Either way, you've got to get it ready, and it has to be delivered to the right person in the right place. Scheduling, it's got to arrive at the right time for the patient. And that patient material needs to be ready to go, etc. And it comes through from there. So at the moment, all of this process is really not centered on the patient. It's centered on other factors around the managed service, scheduling, etc. It's all very difficult. It's fragmented. There's so many people involved in this process. You've got the clinic, you've got the manufacturer, you've got the patient. And then on top of that, you've got logistics actually moving it, and the logistics that are actually moving it are probably subcontracted to somebody else. So it's a hugely complex process, and that's just one element of moving these things. So how do you put all that information together, automate it, and make it safe? So whistling through, we've developed, we've made an announcement and we'll be launching soon, a liquid nitrogen-free shipping solution, which I'm not really going to focus on today, but it forms the center of the automation showcase, if you like, that I want to touch on later on. All of this is controlled and linked through that software. So even now at this early stage in the process, everything that has happened to the starting material that will go on to make that therapeutic product, everything that's happened to it is captured. When it is picked up, it can be controlled through here. You can even book the logistics provider through this particular service and through the automation service here. And everything on this process and protocol is driven through what we call electronic SOPs, or ESOPs. And this picture gives you an indication of that. It's a web-based platform. You can access it from any tablet, your mobile phone, desktop, whatever way in which you can enter the internet. All you need is an internet connection. Okay, not always easy or always possible, but we've done this very much with the manufacturing workflow. So everything we've done here has been focused on the clean room. So if it can be done in the clean room, we've done it. And clearly if it can be done in the clean room, it can be done outside the clean room as well. So using these tools of a simple pictorial guide, which also can act as training tools. So the steps are very clearly outlined as to what you got to do and what's next to flow through from these, and you tap your way through. All the data, etc., of materials or equipment that you use along the way is collected. Anything you use in terms of consumables, barcoded, captured, and recorded. And of course, if you've pre-entered all of your consumables into the system, then it will pick them and it will make sure that everything that you are using is both within standard and within date. For example, any equipment that you use is within its service tolerance and calibrated appropriately. From a logistics perspective, this is just a screenshot from the test that I'll describe in the coming slides. But using the ESOP tool, we created a process which we were able to transfer to the various people, and without any training. These people involved at the clinic, at the manufacturing center, the logistics center, the drivers themselves were able to follow these ESOPs on whichever device they had in order to identify from the packing list what was inside there, confirm that that was the right product, through to integration so that the courier picked it up at the right time from the right place. And then while it's in transit, we can follow it real time all the way down from here, from a distribution center close to London, that way along into South Wales and to Cardiff, where mock delivery took place. So using the various tools and pieces of equipment that we have within the software platform with the ESOPs, you can do all this now. A little bit of the business that I've been fortunate to work with so far is determined to eliminate liquid nitrogen from the process, so we can cryopreserve in a liquid nitrogen free manner. We can ship in a liquid nitrogen free manner. And if you don't like water baths for your thawing, then we have a dry thawing solution, which is all linked in here to do away with the inconsistencies and risk involved with thawing your final product. All of it captured and driven and controlled through the ESOPs and the recording possibilities for Chronicle delivered through Chronicle. So testing this, the partnership or the collaboration, which some may be familiar with here in the UK, is the Advanced Therapy Treatment Centres, or ATTC network. Put on to automatically advanced, apologies for that. So there are three consortia that make up the network, and there are some sort of like coordinating projects. I don't know how I do that. I do it every time. Sample is a project that's focused on the acquisition of starting material. So that's a way forward. The study itself used a number of partners within the Midlands and Wales. Advanced Therapy Treatment Centre, the ATTC network. We had Orbsen Therapeutics, if you like, as the exemplar product. So this is an allogeneic MSC-based therapy. To mimic the starting material piece of this, we lifted the product from their manufacturing centre, where they're based on the west coast of Ireland, and lifted into their British manufacturing centre at Birmingham in the UK, and then we distributed it via a hub for allogeneic products to 3 clinical centres, and World Courier was the shipping organisation that we used. Complex study, number of steps. So I think we had, we got 8 steps in all to do from that. 3 clinical centres, a manufacturer, a distribution centre, a courier, and ourselves. So highly complicated. We linked it all together using the ESOPs, flowed it through from the integration dashboard so that people could constantly see what was going on, where and when. And then finally, once those cells had been delivered or gone through that process and they stayed within the shipping container for the duration of the study, we then did a comparison This just shows the viability of these cells. We use two methods to determine the viability. The first two columns are control cells that remained in Galway from here, and then you can see there is no material difference between the cells that underwent that logistics journey throughout the test. And this data, combined with a report from what we did, formed the basis for IMPD suspicion to show that we can complete these logistics safely for this particular cells for a specific clinical trial. So a whistle-stop tour of some of the things that we're doing around automation and looking into the manufacturing workflow and associated processes there. So thank you very much indeed for your time.
Okay, great. Thanks. So then we'll jump into some questions. So questions for you first, Stina, from Zilong, wondering how TILs were specifically isolated from the heterogenic tumor tissues and being cultured.
Yeah, so as I said, we started with tumor tissue that we made into very small fragments. And there are different ways how to go from that. Either you can sort of do a cell suspension using machines and enzymes to get the TILs out, but we sort of make only that we use scalpels to make micro fragments, and then we have high doses of IL-2 in the medium, so the TILs actually crawl out against the cytokine gradient, and then after that we can split the cells from the plate where we had the tumor to, so we have complete new split wells that are tumor-free, and those we can use to harvest for patient treatment. So our idea is only to stimulate them via IL-2. And of course, then you don't know that you would get T cells, but this will be depending on what tumor type you have, and also what ratios you will get from CD4 and CD8. And I mean, from melanoma, you're lucky because we mainly get out T cells. So it's like 98 or 99% of T cells. And the ratios is always almost higher for CD8 in melanoma. But when I have done this for other tumor types, I still get out the majority, over 90% are T cells. However, you can get different ratios of CD8 and CD4 depending on tumor start.
Yeah. And for Stina as well, great talk. How many patients did you treat overall at this time from Dirk?
So, I mean, it depends a bit how you divide it, but in the MAT02 clinical trial, we treated 5 patients in cohort A and 5 patients in cohort B. And it was more patients that were enrolled because some of them, as I said, unfortunately passed away until we had generated the cell product. The same has actually happened now when we are trying to get these 10 other patients. We have treated 1 patient out of this 10, but for the second that we tried, got too ill to get the therapy within the 6 weeks. But in total, combining the clinical trial pilot, that is a little bit of difference compared to the setup we have today, we have treated around 25 to 30 patients with TIL therapy.
Okay. And then I think this question is for Katrin.
I also think I have a question from Evren in the chat forum.
Yeah, is it for you? How does higher IL-2 reflect to the function and phenotype? 3,000 units per mil confers a lot of additive cost.
I don't know, Katrin, do you want to take it or should I?
I think you should take it because I think it's more your area than mine.
I'm happy if you take it, Stina.
That's good, everyone.
So yeah, so they are super high IL-2 doses, and I agree with that. The expenses are huge, both for the manufacturing, but also when you give these high doses during the manufacturing, you have to give supplementally IL-2 doses in vivo into the patients, which is both costly and is also giving bad side effects in the patient. But regarding to the function and the phenotype, the function is fine. I think there's not really a big difference in function when I have cultured the cells in lower IL-2 versus high IL-2. And the phenotype we had in this setting, we had the majority in the infused TIL population was of course central memory and effector memory cells. You could argue that that would be a problem, but since we can see the clones persisting up to 2 years in the patient, I still think it's okay in regards of that. But yes, it's costly, and other trials have used lower IL-2, and I think in the future that is also what I'm sort of aiming at to introduce also again in our protocol.
I have a question for Katrin. So looking at the protocol that you received from Denmark, so you tried with the wave system right in the beginning and you weren't getting reproducible sort of results, and then you changed to this new protocol, but there was quite a lot of modifications. Was it possible to pull out what the sort of most important changes were for people that are looking to go from small scale to maybe a wave system?
I mean, we used the wave system in both processes, both the small scale and the large scale.
Yeah.
So I think the major changes were that we had a more defined process. We had limits for stuff that we didn't have initially. Limits for how many cells to transfer, limits for the ratio of feeders versus TILs. So I think that's the most important message, maybe, to have a really well-defined process. So you do the same thing every time.
So those batches that would have failed in the end just didn't make it far enough to fail? Or?
One more time, what did you mean?
So like if you had, you know, that you're taking sort of controls as you go, or was it just standardizing that was the benefit and then it was working every time?
No, I think it was making more controls as well, and sort of having limits for when to proceed and when to not proceed.
Yeah, okay. And then we have a question for you, Bill. How do you ensure the batch protocol integrity safety using an internet-based ESOP?
Yeah, sure. So it's built, the software is built on the full GMP compliance. So it's 21 part CFR 11 compliant. Essentially, it's a sign-on thing. So every time you go in and do something on using the software, it's recorded and you can't do anything about that. So who does what, where and when is always recorded. Anybody can, if given the right permission, can write an ESOP, but you cannot use that ESOP until it has been approved and released on the system. And then once it is released, you control who does it. So an ESOP to control logistics, for example, would go to a select group of people, which would be very, very different to the group of people that are performing the rapid expansion step, for example. So that's how it's controlled in terms of that base. It's access, so each individual user has their own unique access point, and then it's controlled through a level of hierarchy as to who writes, approves, and then releases the protocols. Exactly the same as you would do on a paper-based system.